All right, let's move on to chapter 2. This deals with theories and therapies. Yeah, I know this one's going to be pretty complex. Bear with me. And it's really going to focus on the foundational aspects of what psychiatric nursing is based on. Getting started, we're going to talk about psychoanalytic theories and therapies, starting right there at the beginning with one of the founding fathers of psychiatric nursing, psychiatry in general. It's going to be Sigmund Freud. Freud was an Austrian neurologist and really was the founding father of a lot of what we're going to be talking about in these theories today. He was also the founder of psychoanalysis. In this case, we're going to start with Freud's three levels of awareness. The first is your conscious. This is your conscious mind, everything that you're aware of around you right now. Then going deeper, we have your preconscious. These are your memories, your emotions. While not on the forefront of your mind, these are things that you can really easily pick up and recall. And then finally, that bottom layer is the unconscious. These are your repressed memories, passions, unacceptable urges, desires. You can get really deep and disturbing with Freud if you really wanted to. Another of Freud's most famous theories deals with personality structure. Possibly one of the most famous, that is the id, the ego, and the superego. The id's the pleasure principle. It wants to have fun. Your ego's your problem solver. It likes a challenge. Then your superego. That'd be your moral component. An example I like to use in my nursing classes is your id wants that nursing paycheck. It's in it for the money. Your ego, that wants to be a good nurse. It's going to go out there. We've got a full nursing assignment. We got call lights going off, but we're going to manage this caseload today. And then finally, you got your superego. This one wants to really get out there and help people. This is that moral judgment. It's that good listening nurse at the bedside. Freud also dealt a lot with repressed memories. These are defense mechanisms, anxiety. They operate at an unconscious level. A patient had a traumatic event, an embarrassing event. They'll deny it ever occurred. They'll lie. They'll go around it. And it's a way both to protect themselves, ward off anxiety, and try to keep that traumatic event out of their conscious reality. You're also going to find that Freud was very focused on sexuality and sexual theories. In this one, this is Freud's psychosexual stages of development. And he believed that each person went through 5 stages. And while there's a lot of criticism of this theory, it is also one of those founding theories that really set the stage to develop more modern theories. In this case, we're talking about the areas that the infant and the person focuses on for pleasure as they develop, starting with the oral phase at 0 to 1 years, the anal phase from 1 to 3 years, the phallic or Oedipal stage from 3 to 6 years, the latency stage, that 6 to 12 years rolling into puberty, and finally that genital stage in puberty. Freud was the founding father. He really paved the way for a lot in modern psychiatry. But at the same time, a lot of his ideas are seldom used anymore. He set up that framework, but intrapsychic conflicts no longer considered to be the cause of all mental illness. He also had a major focus on things like dream analysis and free association that we've really moved past. Moving on from Freud, we're going to talk about psychodynamic theory. And while we're moving on from Freud, this is really centered on Freud's theories and practice of psychoanalysis. It's a newer model, and it deals with patients talking about their current issues, their current struggles, talking about those childhood traumas, and finding the ways to work through these unresolved issues in their day. All right, first question. According to Freud, which aspect of the personality motivates an individual to seek perfection? Would that be the A, the id, the B, the ego, C, the superego? If you said C, the superego, you are correct. That is that moral component. It wants perfection. It wants that moral right. First case study, Miss V is admitted to your unit after being picked up by police for intoxication and anxiety. After she is stabilized, she spends the rest of the night on suicide watch. In the morning, she's admitted for a stay of 3 to 5 days for evaluation. The police are not pressing charges for disturbing the peace because she has promised to get help. Unfortunately, this is going to be a very common issue you're going to see working in mental health is a lot of intoxication, a lot of people breaking down, having incoherent incidences. And especially for us in Ohio, we call it a pink slip. Each state's going to have one different. I know Texas and Ohio have that 72-hour hold, which seems to be really common. But keep in mind, this is all going to vary slightly from state to state. A patient comes in saying they're suicidal. How long can they hold them? That is dictated by state law, where that doctor can write a pink slip, have you involuntarily committed for up to 72 hours for evaluation to try to make sure that you're not a danger to yourself or others. It gets really common around the holidays as well. You'll see one patient that really comes to mind with me was a guy came in on Christmas Eve. He was drinking some beers, told his wife he was going to kill himself, and yeah, he spent his holidays right there on the psych ward with the involuntary hold. Like the guy was just going through a lot, not necessarily severely mentally ill, had too many beers, threatened to kill himself, and unfortunately, that's all it takes. Next, we have interpersonal theory. In interpersonal theory, all persons have certain expectations or needs that are met through interpersonal interactions. And the purpose of this is to reduce or avoid anxiety. Anxiety is common in everyone. Everyone has some anxiety to a certain extent. When we talk about anxiety disorders, we're talking about when that anxiety comes to such a level that it's having a negative impact on the person's life. At the same time, just having a little bit of anxiety, that's normal. Everyone's got it. In interpersonal theory, the avoidance of this anxiety is actually guiding our behavior and interpersonal interactions. From interpersonal theory came interpersonal therapy. In this case, interpersonal therapy is best helping a patient come to terms with grief, the loss of a loved one, major role transitions such as a traumatic divorce or a loss of a major job. In this case, interpersonal therapy focuses on helping the patient both mourn that loss as well as develop the coping skills they need to move forward and come to terms with this traumatic event. For our second question here, second part of our case study, dealing with our case study, we're going to have some terms we haven't really dealt with yet, but we'll go ahead and divide them. We'll work through them together, see if you can figure out and which is the best fit here. We had our patient coming in, Mrs. V, and as you begin working with her, you notice Mrs. V has an uncanny resemblance to your younger sister. As a child, the sister lied and criticized you constantly, then screamed and cried to others if you challenged her. You realize that you are responding negatively to this patient. What's going on? A is mutuality. Mutuality would be just breaking it down exactly like it sounds. That'd be a symbiotic relationship where everyone involved benefits. B would be self system. Self system is a psychological theory that deals with that natural response to relate to others. How you have a natural desire and ability to communicate and respond positively, negatively, and relate to others within society. Option C is self-actualization. That's going to be your highest level of Maslow's. I'm sure you've heard Maslow's before, and we will be covering it much more in this course. And in that case, that self-actualization is actually that highest point on the pyramid where full potential is realized. And finally, D, countertransference. The answer is going to be D, and let me break down exactly what transference and countertransference is, because that's going to come up a lot both here within the course. I can guarantee it's going to be in your ATIs, even possibly NCLEX. In the case of transference and countertransference, transference would be you're working with a patient, and that patient, in this case, says that you remind them of their little sister. That patient is going to have inappropriate feelings towards the nurse. That is transference. That patient is transferring inappropriate feelings towards the nurse. On the other side of that is countertransference. That Florence Nightingale effect they used to talk about a lot. In this case, that would be the nurse developing inappropriate feelings towards their patient. In this case, the nurse feels like Mrs. V reminds them of their childhood. Of their younger sister. They had an extremely negative relationship with. And the nurse is now transferring those negative feelings onto the patient, in this case, countertransference. Easy way to break it down is just patient to nurse is transference. Nurse to inappropriate thoughts from the nurse to the patient is countertransference. Now that you've identified the personal struggles you have in working with this patient, you've identified the countertransference, the inappropriate thoughts you're having about your patient, what should you do? And you've done the best thing there. You have identified this phenomenon, this countertransference occurring. Once you have identified those inappropriate thoughts, you are able to avoid them. You are able to realize that you have an ethical duty to treat this patient in a fair, objective way. You know, they're not your sister. They did not harm you. They did not have that struggles that your sister did. Once you can identify those inappropriate thoughts, you can put those to the side. Really let your super ego take over and deal with this patient fairly and professionally. Mrs. V reveals that she's been drinking heavily over the last couple of weeks when her boyfriend tried to break up with her. During her stay, she receives medication for depression and begins having sessions for interpersonal therapy. This is something you'll see a lot in mental health nursing, in that people with underlying mental health disorders try to self-medicate. They'll self-medicate with alcohol. They'll self-medicate with illicit drug use. And often this substance abuse tends to make the problems worse more than it helps. Moving into more modern theories, a name you're going to hear a lot is Peplau, Hildegard Peplau. In this case, Peplau focused a lot on the interpersonal relationships between the nurse and the patient, between the provider and the patient. In this case, the nurse is both a participant and an observer. And the nurse's role is to interact, develop a relationship with that patient, help to lower that patient's anxiety in order to help them open up, come to terms with their problems, and greatly increase their response to treatment. All right, we've covered a lot of our developmental and interpersonal theories. Let's get down to the more interesting ones, at least from my perspective. These are these behavioral theories and therapies. Moving forward into behavioral theories, one that you've probably heard of a lot is Pavlov and Pavlov's dogs. In this case, Pavlov was a pioneer. He created an experiment where he would actually ring a bell before giving his dogs a treat. And a little cruel, he actually hooked devices to the dog's salivary glands. And after a few repetitions of ringing the bell and giving the dog a treat, he was actually able to prove that when ringing that bell, the dog's salivary glands would begin to secrete, proving that they associated the ringing of that bell with the positive reward and acted appropriately. John Watson then took his experiment a step further and actually contended that many of your actions and responses to the day, both adaptive and maladaptive, both good actions and bad actions, are a result of similar traits in your body reacting to the external stimuli through a trained way. And finally, you had Skinner. He researched operant conditioning. This is a method of learning that occurs through rewards and punishments for voluntary behavior. These behavior responses are elicited through positive and negative reinforcement. So whereas Pavlov mainly worked with the positive reinforcement getting that result, Skinner then took it a step further and was actually studying both positive and negative reinforcements, punishments, to see what results that had in the person's actions. We have a video in the material on the Little Albert experiment, which, looking from today's standards, was a little cruel. The ethics and morals involved in scientific research were a little looser back in the 1920s. I'm going to leave the video within the slides. You're welcome to watch it on your own. Generally speaking, Dr. Watson took Pavlov's experiment and took it a step further. Whereas Pavlov was introducing that positive stimuli and observing the response on the dogs, Dr. Watson was introducing negative stimuli and recording the reactions of this 9-month-old child called Little Albert. Little Albert was the son of one of the nurses at the hospital. While we're not sure how much the mother knew, we know she was paid $1, like $15 in today's money. And in this experiment, they would bring little Albert out, and they would expose him to a fluffy bunny, a fluffy rat. And when the fluffy rat was brought out, they'd make a real loud sound by hitting a metal pipe with a hammer, making little Albert cry. Eventually, after a few repetitions of this, as soon as you'd bring the rat out, little Albert would then begin to cry when no negative stimuli had been introduced. It was confirming the same results that Pavlov studied, but now we're doing it on a 9-month-old child. They ended up taking the experiment even further. He'd have a big scary mask he'd put in the kid's face. It is not an experiment that would be legally conducted today. Back in the 1920s, when psychology was in its infancy as a science, this was groundbreaking material. It's a very interesting video. It's real well explained, and it's there in the material if you'd like to watch it. Just something to think about in this. What are your thoughts about the experiment? Did the benefits outweigh the negative impact that it could have had on little Albert? I mean, this is a kid that could have went through his whole life with just an irrational fear of fluffy little bunnies and fluffy little rats. At the same time, we did learn a lot about human psychology. There was that connection. Building on what Pavlov learned is now extended into humanity. Obviously, this is not something that could be legally done today. I know for colleges, there's what's called an IR board. Now, when I was doing my doctoral dissertation, I did my dissertation on tuberculosis in the homeless population. And while I was doing nothing negative, I was going to homeless shelters, providing education, but I was also screening for tuberculosis. And even just that, the amount of approvals, privacies, everything possible to protect those patients from any possible negative result. And rightfully so. And a lot of that is the result of these experiments in the 1920s, such as little Albert. Just some definitions as we go further into the material. The first would be a term called modeling. In this case, the therapist provides a role model for a specific identified behavior, and the patient learns through that imitation. Second is operant conditioning, which we've touched a bit about. This is the basis for behavior modification. Uses positive reinforcement to increase desired behaviors. We stay away from the negative reinforcement like little Albert. Second is exposure therapy. It's used for people who experience anxiety due to fears, phobias, or traumatic memories. In exposure therapy, patients are encouraged to face their fears and emotionally process them in a safe environment. This is often used in things such as a lot of patients will have fears of elevators, fears of bridges. In this case, they'll gradually expose the patient more and more to an elevator until they're eventually riding the elevator and becoming more comfortable with that fear. I used to know a patient that was very afraid of bridges. And living in Cleveland, we have a big river that runs right through the middle of the city. Kind of cuts off a lot of the town for you. Finally, we have aversion therapy. This is pairing a target behavior with a negative stimuli in order to extinguish an undesirable behavior. You'll hear patients that quit smoking. I know there used to be a quitting smoking technique where they'd put a rubber band on their wrist, and every time they'd want a cigarette, the patient was instructed to snap their wrist with that rubber band to try to psychologically equate that desire for a cigarette with that painful stimuli. And finally, biofeedback is used for controlling the body's physiological responses to stress and anxiety. Moving on, let's talk about cognitive theories and therapies. Cognitive theory and therapies, these deal with the interplay between an individual and their environment, the thoughts and feelings that patient has about the world around them. Thoughts about the world and our place in it are based on our own unique perspective. Everyone's had a different path through life, and they process the world around them in wildly different ways. And in these theories and therapies, we help the patients overcome the negative thoughts, irrational fears, and negative responses, helping them to increase their functioning in the world around them. Two therapies we're going to be focusing on within the cognitive theories are the rational emotive therapy by Ellis and the cognitive behavioral therapy by Beck. And in both of these techniques, we're helping the patient to recognize irrational and distorted beliefs. And they can both identify those irrational, distorted beliefs and help to overcome them, to help them to process them in more accurate ways. Trauma-focused cognitive behavioral therapy. This is a newer treatment developed to address serious traumas such as sexual abuse in children, expanded for traumas, PTSD of all ages. In the short term, incorporating caregivers and family therapy, and helps them to identify feelings and how to manage and move past this trauma. Next, we have dialectical behavior therapy. While our other two therapies dealt more with irrational thoughts and beliefs, dialectical behavior therapy helps the patient identify antisocial negative actions and behaviors that they're exhibiting. And once they can work with the therapist to identify these negative behaviors, to hopefully change that to a more positive and avoid those antisocial actions. Another cognitive theory involves dialectical behavioral therapy. And this is an integration of opposites. That dialectical strategies to help the patient and the therapists to talk about and give up extreme positions. And this is focused and developed for individuals with intractable behavioral disorders involving emotional dysregulation. One thing to think about, nobody expects you as the nurse to be implementing dialectical behavior therapy for your patient at the bedside. These are for psychologists, therapists. For us as nurses, we need to be aware of this. We need to be aware of the different treatment modalities that our patients could be going through. We also need to be aware of the purpose of some of these. Just as in Pavlov's dogs, just as in Little Albert, these patients have built up subconscious reactions to what we would consider normal stimuli. And it's to not only be aware of these reactions, but to help our patients work past these in a healthy manner. Moving on, getting more modern as we go, let's move on to humanistic theories. The first one's going to be the theory of human motivation. This theory asserts that psychology must go beyond the negative experiences of hate, pain, misery, guilt, and conflict to include more positive emotions such as love, compassion, happiness, exhilaration, and well-being. Human beings are active participants in life, striving for self-actualization. Again, coming back to that self-actualization, which we're going to talk much more about in our next slide with Maslow. And when these lower needs are met, we can eventually move up the ladder to gaining more and more positive levels and hoping to eventually achieve that self-actualization. We talk a lot about Maslow, and you're going to hear it come up in a lot of different areas of nursing. It's actually one of those basis of NCLEX questions, where that very lowest need to be met, the very bottom rung of that Maslow is physiologic needs. Food, water, oxygen, everything that patient needs to live right now. This actually comes up so often because that is the basis of answering NCLEX questions accurately. If that patient does not have oxygen, airway, breathing, circulation, everything that they physiologically need to live right now, the other ones are meaningless. Once they have those basic physiologic needs met, then we can move on to safety, because that's, again, coming into NCLEX questions. Once we have all the basic physiologic needs, NCLEX is testing you on what danger is that patient in. If you give the patient metoprolol, our priority as nurses is going to be to assess that heart rate, because severe bradycardia could then again deprive them of that physiologic need for circulation. Got that bottom rung physiologic needs. We've next moved up to safety. We've identified any dangers to the patient. Then your next one's going to get into more of the psychosocial needs, very necessary for mental health and psychology. NCLEX is not going to necessarily be asking you so much about their need for love, belonging. You may hear that a bit in your pediatric courses, getting in through their stages. Once they've got that love, belonging needs, then we've got the esteem needs, and then finally self-actualization at the very top. And we can't talk enough about Maslow. This is going to come up in every area of nursing. And got to keep in mind that it's a building block. It starts with those physiologic needs, that warmth, food, water, shelter, everything they need to survive, moving up to safety. And each human being is striving to move up each rung through Maslow to reach higher and higher levels until they eventually reach that level of self-actualization. No, that Maslow's important. Matt Maslow is the cornerstone of what we do. Make sure you're going forward are really good with that Maslow's pyramid. And it's important for us as nurses. We can break down exactly what that patient needs to thrive, what that patient not only needs to survive, any dangers that patient's in, but also helping them live their life to the fullest. What is most important in the sequence of nursing actions? It really does come up a lot once you get really good with especially identifying what's a physiologic need versus a danger. Those NCLEX questions are written in a very rigid way. There's a whole office in Chicago, the NCSBN, whose entire job is to write NCLEX questions. And you'll hear a lot of times students talk about nursing questions have multiple correct answers. You generally only hear that in the lower levels of nursing, because as you get going, you realize there really is only one correct question. The other options could be sort of correct, sort of saying your patient's only sort of dead. Sorry, I'd say. In this case, we have to have those physiologic needs met. Once if that patient is lacking one of the physiologic needs, that is going to be one of your NCLEX answers. From there, if we have all those needs, you can then move on to protecting the patient from risks and dangers that they may be in. Biologic theories and therapies. Moving forward, getting out of the more thought-based theories, and we're getting more into the biological, dealing with those imbalanced brain chemicals. That biological model, it's focusing on neurological explanations for these adverse thinking, these chemical imbalances. Imbalances of serotonin, imbalances of dopamine can have serious negative effects on a patient psychologically. Also, not to be discounted, things like genetics. A lot of people are genetically predisposed to things like anxiety, genetically predisposed to depression, schizophrenia, bipolar, and how the body and brain interact to create these emotions, memories. And often it's a very complex web of individual parts combining to create the sum of the patient's behaviors. I know we touched a bit on this in chapter 1 as well, and that's not to discount the patient's environment, how they reacted on their mental state. Some people are much more resilient. Some patients have a much greater ability to handle stress than others. There's nobody that's completely mentally ill and there's nobody that's perfectly mentally healthy. Everyone falls somewhere in between there. And there's a lot of patients that just that increased amount of stress can really push them over the top. Same thing with cultural aspects. There's some patient cultures where they're very open. They will talk to you about their problems. They're very receptive to treatment. And then there's other cultures where they do not talk about their mental state. They're going to be very closed off, and they're going to be much more resistant to treatment. Other factors to consider is going to be economic factors. It's pretty fair to say that things are not going economically great in this country right now. Prices at the grocery store are increasing monthly. Some people out there are really struggling, and that is a significant amount of increased stress placed on patients that maybe were already somewhere in the middle of that mental health spectrum. Other biologic therapies, a big one's going to be pharmacology and pharmacotherapy. I don't want to say that psychiatric medications are the cornerstone of modern psychiatry, but psychiatric medications are very, very, very common. There is very few patients that are made their way into inpatient psychiatric institutions that are not on some form of medication or other. And we're going to be getting deeper into psychiatric medications later in this chapter or later in this course. Other physical biologic therapies would be everything from electroconvulsive therapy, ECT. If you saw that Jack Nicholson movie, One Flew Over the Cuckoo's Nest, and that is still very commonly used. What electroconvulsive therapy is doing is we're basically inducing a seizure within the patient's brain, trying to reset that nervous system. And a lot of patients really swear by the efficacy of this. It's used major depression as a common usage for this ECT, that electroconvulsive therapy. And for us as nurses, not even going to that ECT facility, we're going to be in charge of caring for that patient both before they go and after they return. And there's going to be a lot of patient dangers, a lot of safety considerations for us. Making sure that patient has been MPO because they're going to be getting anesthetic and sedatives while they're going through this procedure. And then when they come back, the nervous system disruption, making sure they're not a false risk, they're not in danger to themselves. Make sure we're closely monitoring them on their return. Other ones, deep brain stimulation, vagus nerve stimulation, transcranial magnetic stimulation. All of these treatments are used to introduce a stimuli to hopefully correct a neurological imbalance, a neurological dysfunction. A lot of the different treatments and therapies we've discussed, it's not necessarily only one treatment. It's going to be a multitude of treatments combining together to benefit this patient. One basic thing you're going to hear a term within psychiatric nursing is milieu, maintaining a therapeutic milieu on the nursing floor. And when you hear the term milieu, it just means environment, just a fancy term for environment. When you get to clinical on your first day, compliment the therapeutic milieu, or say something about the milieu. But anyway, you're going to see a lot of different approaches. It's going to be both group therapy, individual therapy, combined with pharmacologic therapy, maintaining that therapeutic milieu environment of the unit, along with a therapeutic relationship between the nurse and the patient. And it's all going to come together to maintain one effective treatment. Next, let's talk about developmental theories. That childhood growth and development goes a long way into forming who both you and your patients are as a healthy adult. The first developmental theory we'll talk about is going to be Jean Piaget. And this one deals with the cognitive development throughout childhood. You first have that sensory motor development from ages birth to 2 years old, when they're learning how to control their body. They're very disorganized. Next, we got that pre-operational stage from ages 2 to 7. They're starting to figure things out, figure out the world around them. Moving on to the concrete operational stage from roughly ages 7 to 11. They're starting to figure out how the world works, where they fit in with it. And then finally, you got that formal operational stages from ages 12 throughout adulthood. And there's a great YouTube video embedded within the slides there as well if you're looking for any further explanation on those stages. Possibly the most common developmental theory you're going to hear a lot about is Erickson's. Especially, I know you're in taking your peds this semester as well. Knowing your Erickson stages going in is going to really set you ahead, because I can guarantee you're going to get at least 1 or 2 questions related to Erickson's in that course. And there's a reason for that. It comes up a lot in NCLEX as well. It starts in that early stages, that trust versus mistrust. Move from roughly 0 to 1.5, 1 year, year and a half. And then moving into that toddler stage, that 1 year to 3 years. I can tell you, I've got a 3-year-old at home right now. They're stubborn. They really want to take initiative. They want to do things for themselves. And just playing into that, giving them choices. Would you like to have milk or juice with your lunch? Can go a long way in getting them to go along with you. And that's a thing that they're bringing up with NCLEX as well. There's things like initiative versus guilt from 3 to 6, industry versus inferiority. When you see Erickson's coming up in NCLEX questions, I remember there used to be an HEI question years ago about a 9-year-old's on your nursing floor, and what can you do to help them maintain their Erickson stage? Well, the answer is industry is industry. What is the industry for that kid? His industry is schoolwork, so it's making sure that his homework's there and available for him to keep up with his peers. There was another similar question along those lines that dealt with a teenager, a 16-year-old's on your nursing floor. What can you do to make sure that he maintains his Erickson stages? With industry versus role confusion, identity versus role confusion, it's making sure his friends can visit, making sure he has a little bit of a social life, maintains his social life. He's got his phone so he can text his friends to keep him up with the rest of his peers. And then moving forward, intimacy versus isolation, that 20 to 35, they're out getting married, developing a family. Then middle age to 35 to 65, generativity versus self absorption. And then finally, that integrity versus despair for the elderly. Mostly when you see Erickson's, especially on NCLEX, they're going to be dealing with children through teenagers. Rarely are you going to see the NCLEX questions coming up with intimacy, generativity versus self absorption. It's usually going to be helping a child maintain those Erickson's milestones. Another one you may hear come up is going to be the theory of object relations with Mailer. And this one has to do with familial relations and the importance of family relations and social relations in maintaining those developmental milestones. They'll talk about the object being that significant person, the mother, the father, and the issues that can cause, the disruption that can cause their life. Say there was an early separation or there is a relationship problem within that family. Other theories of moral development, one is Kohlberg's stages of moral development. And his theory provides a framework for understanding the progression from black and white, rigid thinking about right and wrong to the complex shades of gray that is more of the real world and reality. Kohlberg's stages of moral development has three levels: that pre-conventional level, obedience and punishment, individualism and exchange. Moving on to that conventional level, that good interpersonal relationships, maintaining social order. And finally, that post-conventional level, that social construct, individual rights, universal ethical principles. And think about your own school age years, your own development. That stages of obedience, punishment, individualism, and just that levels of growth and moral development that we all go through. Another in this line of ethics and care is going to be Gilligan. Gilligan and Kohlberg worked closely together and later had a split professionally as Gilligan felt like his work favored males, suggested that morality of care should replace Kohlberg's justice view. Gilligan had more of an emphasis on relationships, banding together. I know that these modules on theories, they can be difficult. They can be tough. No one expects you to have a complete in-depth knowledge of Kohlberg and a complete in-depth knowledge of cognitive behavioral therapy. But knowing generally what each theorist was focused on is going to go a long way in helping you get through these. You see Gilligan, you see Kohlberg, we're talking about ethics. We start talking about Piaget, we start talking about Erickson's, we're talking about developmental stages. We talk about Pavlov or Watson, we're talking about operant versus classical conditioning, and having a good idea of what each was focused on. And last slide, again, if you have any questions on these, feel free to reach out anytime. You've got my email there in the Blackboard. I've also left my number in there. Any questions you have, just a quick question, shoot me a text, shoot me an email. I'm happy to break down anything you got. If you have a question on a specific slide, just shoot me an email. Let me know, hey, I'm unsure what's going on here in chapter 2, slide 15. And I'm happy to break it down for you that way. If you're still unsure after that, we could also jump on a Zoom call, do a quick phone call. Anything you need, let me know. I know this module on theories was tough. I don't want you to feel overwhelmed on it. As we get moving, we're going to get much more into concrete treatments. We're going to get much more into traditional nursing interventions. I don't want you to feel overwhelmed with this. At the same time, it's really important to have that foundational theory, just a good idea of where we're coming from, good idea of what we're doing when we treat our patients. But anyway, that's the end of chapter 2. Have a nice day.